in esophageal disease, we're starting to learn a lot more about how Barrett's esophagus and ablation therapy for Barrett's esophagus is both safe and durable. We're also interestingly seeing that there is a recurrence rate that people who undergo radiofrequency ablation should stay in surveillance because even though there probably is only a small rate of recurrence with actual cancer, people do still require surveillance to make sure that they haven't developed recurrent dysplasia and that which could eventually need treatment. Fortunately, treatment of the recurrence does seem to be quite easy and can be done in a simple session. One of the other highlights, there was a study done on something called FISH, F-I-S-H. It was an acronym, and what they're doing is they're taking an assay of Barrett's tissue, and they're noticing that a group of people that had positive assays had a higher likelihood of progressing among patients with no dysplasia in Barrett's. So even though this isn't quite ready for prime time and not quite ready to be put into practice, I think what we're going to see is more and more development of stratification tools so that patients with Barrett's esophagus can be appropriately surveyed even if they have no dysplasia. So those are the highlights. Actually, I think one of the most intriguing studies was a study that was presented out of the Arizona group using a drug called Roserem, R-O-Z-E-R-E-M, for patients who have both GERD symptoms and chronic insomnia. What they hypothesized was that patients with insomnia could have worsening GERD, and patients with GERD could have worsening sleep patterns. So this seems to have treated both the GERD symptoms as well as the sleep problems. And one of the rationales for the way the drug works seems to be related to melatonin. There's some very scant but developing data with melatonin, and this could potentially lead to a significant new treatment. So if you didn't see this study and you weren't here, look for it when it comes out in press. I think that really is going to change our paradigm for actually how we treat refractory GERD. The thing that's going to change how I practice, there have been a couple things. One poster in particular today that I thought was interesting was that in patients who complain of dysphagia that do not have any endoscopic finding suggestive of eosinophilic esophagitis, they found a very low prevalence of eosinophilic esophagitis, and they suggested that it's not worth biopsying because of the low rate and because of the cost of biopsy. So I'm going to use that to support my position that if an esophagus really looks normal, even though someone complains of dysphagia, I'm not planning on biopsying them, despite some of the other data that came out several years ago. So that's one change.
Anything else you want to add?
That's it. If you can catch me on Twitter if you want. I'm Ryan Madanick, MD, R-Y-A-N-M-A-D-A-N-I-C-K, MD. If you're on Twitter, go ahead and follow me there.